My talk today is on hidden and often missed lesions during arthroscopy. And these are the lesions which are often there, but for some reason you don't see them. And according to some surgeons, they are there, but you don't see them. Some of these lesions are truly hidden, like loose bodies and incomplete meniscal tears. Others go undetected because of surgical inexperience, as in a PCL injury, or technical inadequacy on part of the surgeon, for example, inability to visualize the posterior compartments. And some are missed because of the overconfidence of a senior arthroscopist who may overlook or under-evaluate some of the key areas of the knee. So to list some of the commonly missed or overlooked lesions, actually if you go to see it, practically covers everything, as anything can be missed in the knee if you're not careful. Missing these lesions can significantly affect surgical outcomes, and the effects can be seen either almost immediately after surgery. For example, recurrence of symptoms like locking if you have not removed a loose body. It could affect short-term outcomes. You have missed a meniscal lesion in an ACL deficient knee, and a few months later the patient comes to you with a locked knee with a bucket handle. It could be a long-term failure of your surgery. You could miss out on collateral injuries along with an ACL, and the patient may come back to you with a failed ACL a few years later. Or it could be a complete disaster where you have done an ACL reconstruction in a PCL deficient knee. So what are these truly hidden lesions? Some of these are like loose bodies are truly hidden. There are enough and more hiding places for the loose bodies in the knee. There are synovial folds and gutters. And here is an example of a loose body which we were trying to hunt for. We went into the posterior compartment. We used a sucker to try and suck out that loose body. We couldn't locate it anywhere. Finally, when we went into the lateral gutter and looked at the popliteus area, it was there nicely hidden and stuck in the popliteal gutter, and one had to create a popliteal portal to dislodge this loose body and retrieve it. An intrasubstance tear of the meniscus can be easily hidden and missed. This is a 40-year-old man who had classical symptoms of the meniscus. He had medial joint line pain, he had limp. The MRI did show a tear in the meniscus. When you went in, you found that the meniscus was looking absolutely normal. But we went ahead and started trimming this meniscus because I had seen a number of patients who had these kind of intra-substance lesions of the meniscus. And as you trimmed the meniscus, you soon found out that there was sure enough a horizontal cleavage tear. And these tears are very often associated with parameniscal cysts because the synovial fluid leaks out through these horizontal tears and can result in a parameniscal cyst. Inexperience and lack of technical expertise can lead to missed lesions. Classically, it is seen in the posterior cruciate. The ACL has grabbed all the attention, and the PCL has largely been overlooked by arthroscopists at large. PCL lesions can be well concealed and missed, as often the overlying synovium is intact, and unless you shave the synovium over this PCL, you may not be able to visualize a PCL injury. On top of this, to confuse the arthroscopist even further, in a PCL deficient knee, you have a sloppy ACL, the sloppy ACL sign, and therefore surgeons very often end up doing an ACL reconstruction when actually it is a PCL deficient knee. In Strobel series, almost 14% of his patients who underwent PCL had actually undergone an ACL reconstruction because of this kind of a misdiagnosis. The problem is then compounded because the healthy ACL has been sacrificed and replaced by an artificial graft. The PCL goes unaddressed, and very often these patients come to you later with a posterior capsular contracture. Now, an important but often underutilized tool in the armamentarium of the arthroscopist is the probe, and palpation of articular cartilage and probing of menisci are extremely important to unravel hidden lesions. This is a 20-year-old male who came to us with unexplained pain in the knee. His MRI was obviously normal. MRIs don't really reveal softening of articular cartilage, and softened articular cartilage as a cause of knee pain is entirely an arthroscopic diagnosis. You can see that the femoral condyle is firm, but as soon as you palpate on the tibial end, you find that there is gross softening of articular cartilage, and that could explain the pain that this athlete was experiencing on exertion. A meniscal tear can be missed again if you don't make use of the probe. Here is one example where unless you probed it, you could not have seen the displacement of the meniscus. If you miss these kind of tears, these are usually associated with ACL deficient knees, you will find that these patients come back to you with a meniscal symptom a few months after you have done an ACL reconstruction. When you look at the meniscus, don't just come to a diagnosis immediately. Always define the pattern of the meniscal tear. Here is an example where you feel that the meniscus is torn in the periphery, and it's only when you probe it that the flap which is enrolled under the meniscus can reveal the tear of the meniscus. Even a high-grade ACL tear at the femoral insertion can be missed if probing and joint positioning are not done methodically. The ACL in this case looked normal even with probing, and unless you really took the leg in a figure of 4 position and looked at the femoral attachment of the ACL, you would have missed a ACL lesion. Optimum arthroscopic evaluation requires synchronized movements not just of the scope but appropriate joint maneuvers as well. You have done a nice meniscectomy and then you start wondering why is the patient not getting the desired result. It is only when you flex the knee that you can see that there is extensive damage on the posterior aspect of the medial femoral condyle, and this would not have been revealed if you had not flexed the knee adequately after doing a meniscectomy. During an international arthroscopy meet, when surgeons were asked for a show of hands as to how many of them routinely look in the back of the knee, a handful raised their hands, some of them very hesitantly. The NHS documentation form for arthroscopy has a column for the posterior compartment evaluation. My colleague, who was there for almost 2 decades, tells me that till recently this was left blank. That means surgeons never looked in the posterior compartment. Lesions that are significant and can be missed in this area are meniscal root tears and meniscocapsular separations, and that is what I am going to focus on. So you have the posterior root of the menisci, which are right in the posterior compartment, and you can have meniscocapsular separations in the posterior horn area like this. So these lesions in this area are quite frequently seen along with ACL injuries. It is called a ramp lesion. To approach this area, one has to gently pass the arthroscope between the PCL and the medial femoral condyle. As you can see here, the arthroscope is going between the PCL and the condyle. And once you go in, you can visualize the junction between the posterior horn of the medial meniscus and the capsule. When you go in, you may find a classical ramp like this, where the capsule has fallen away from the meniscus, or it may be a hidden ramp lesion. So you need to gently pass a needle through the posteromedial capsule and probe this capsule to find out if there is any laxity in this area. As can be seen here, when you probe the meniscus, the capsule, you find that there is definitely a rent in this area, and this is a classic ramp lesion. Now, missing out a ramp and posteromedial capsular injuries can result in persistence of subtle instability or even an early failure of your reconstructed ACL, as can be seen from this diagrammatic illustration. Another commonly missed lesion in the posterior compartment is the meniscus root. Medial meniscus root tears are commonly seen in middle-aged and are relatively atraumatic in origin. Lateral meniscus root tears, on the other hand, are often traumatic and seen along with ACL tears. Root tears where the meniscus is healthy should always be repaired, as If you don't repair a root, and this is the technique of repairing a root, you have a device to pass a suture in the root. You replace a high tensile suture with a tape so that it gives you a broad area of fixation, and then the root is fixed via a tunnel through the tibia. It's important to repair the root because a root tear disrupts meniscus function, resulting in gradual extrusion of the meniscus, increased joint contact pressures, and it has been compared to almost results of a complete meniscectomy. Despite its functional importance, the popliteus is underappreciated and incompletely evaluated often during arthroscopy. We have seen a number of popliteus tendon lesions which are associated with PCL or ACL injuries. The popliteus may be seen as a hemorrhagic structure. It could be seen where the synovial sheath has been lacerated. The popliteus could be avulsed completely from its femoral attachment, as can be seen here. And even in this case, who was a professional footballer, you can see avulsion of the popliteus. The popliteus can be fixed either arthroscopically, or in some cases where there is a bony nodule, you could do an open fixation of the popliteus and reattach it at its anatomic place. Where the popliteus has been significantly damaged, one can do a popliteus sling operation. Intra-articular ganglionic cysts and localized tumors like PV and synoviomas can be encased in synovium and truly hidden. And unless you explore for these and shave off the synovium on top, you may miss out these ganglionic cysts or tumors. Finally, in conclusion, hidden and missed lesions should be looked for carefully. Addressing these lesions may prevent or delay joint degeneration as in a meniscus root, or restore optimal knee stability as in a ramp lesion. Thank you very much.